Assalamu alaikum. This lecture is about the development of gut tube. Initially, the process of gastrulation will form the three germ layers, ectoderm, mesoderm, and endoderm, during the third week of development. As a result of cephalo-caudal and lateral folding of the trilaminar germ disc, a portion of yolk sac is incorporated into the embryo, forming the primitive gut tube. In the cephalic and caudal parts of the embryo, the primitive gut forms a blind ending tube, the foregut and the hindgut. The middle part, the midgut, remains temporarily connected to the yolk sac by means of Ventral duct or yolk stalk. Foregut, hindgut, and the midgut remains connected to the yolk sac by means of the Ventral duct or yolk stalk. So the primitive gut tube has three parts: foregut, midgut, and hindgut. Foregut, midgut, and hindgut. The interior end of the foregut is closed by oral plate, oropharyngeal membrane or buccopharyngeal membrane that ruptures a third week to connect the foregut tube and amnion. The posterior end of the hindgut is closed by cloacal membrane that ruptures a seventh week to connect the endodermal and ectodermal parts of the anal canal. The foregut consists of two portions, proximal and distal. The proximal foregut consists of the pharyngeal gut or the pharynx, which extends from the buccopharyngeal membrane to the respiratory diverticulum. The distal foregut or the distal portion of the foregut extends from the pharyngeal tube to the liver bud. The midgut extends from the liver bud to the junction between the right 2/3 and the left 1/3 of the transverse colon. The hindgut extends from the left 1/3 of the transverse colon to the cloacal membrane. Endoderm forms the epithelial lining of the digestive tract and gives rise to the parenchyma of the glands, such as the hepatocytes or liver cells, and exocrine with endocrine portion of the pancreas. Muscle, connective tissue, peritoneal components of the wall of the gut are derived from visceral mesoderm. Mesenteries. In general, mesenteries are double layers of peritoneum that enclose or suspend organs and connect them to the ventral and dorsal body wall. The mesenteries between two organs or one organ and the body wall are known as the peritoneal ligaments. Both mesenteries and peritoneal ligaments serve as a pathway for vessels, nerves, lymphatics to and from the abdominal organs. So the foregut has ventral and dorsal mesogastrium. The midgut and hindgut has only dorsal mesentery. Ventral mesentery or ventral mesogastrium exists only in the foregut. It extends from the terminal parts of the esophagus, stomach, and upper parts of the duodenum. Ventral mesentery is derived from the septum transversum. The growth of the liver divides ventral mesentery into lesser omentum, extending from lower parts of the esophagus, stomach, and upper part of the duodenum to the liver. Falciform ligament extend from liver to the ventral body wall. Dorsal mesentery suspends the caudal part of the foregut, midgut, and major part of the hindgut from the dorsal abdominal wall. In the region of the stomach, the dorsal mesentery forms dorsal mesogastrium. So the dorsal mesogastrium in the region of the stomach forms greater omentum, gastrosplenic and gastrophrenic ligaments. Dorsal mesogastrium, dorsal to spleen, forms lienorenal ligaments. In the region of the duodenum, dorsal mesentery, it forms dorsal mesoduodenum. Dorsal mesentery of the jejunal and ileal lobes called mesentery proper. In the region of the colon, it forms dorsal mesocolon. This figure shows the ventral mesentery or ventral mesogastrium is divided into two parts. Lesser omentum extending from lower part of the esophagus, stomach and upper part of the duodenum to the liver. So the lesser omentum is located dorsal to the liver. Falciform ligament extends from liver to the ventral abdominal wall and housing an umbilical vein. So the ventral mesentery or mesogastrium exists only in the foregut. Dorsal mesogastrium found in the region of the stomach, and the dorsal mesentery in the duodenum forms dorsal mesoduodenum. In the region of the jejunum and ileum forms mesentery proper, and in the region of the colon forms dorsal mesocolon. This is the lesser omentum. Falciform ligaments connect liver to the ventral abdominal wall, and this is spleen formed within two leaves of the dorsal mesogastrium. This is gastrolineal ligaments connect the spleen to the stomach. This is lienorenal ligaments connect the spleen to the dorsal abdominal wall in the region of the left kidney. Blood supply of the GIT or gut tube. Dorsal to the gut tube lies the dorsal aorta. Celiac trunk supplies the foregut. Superior mesenteric artery supplies the midgut, and the inferior mesenteric artery supplies the hindgut. Foregut give rise to the pharynx, esophagus, stomach, proximal part of the duodenum, liver, gallbladder, and pancreas. Esophagus. When the embryo is 4 weeks old, the respiratory diverticulum or lung bud appears as an outgrowth at the ventral wall of the foregut. The two esophageal ridges fuse to form tracheoesophageal septum, separate the lung bud from the foregut. So the foregut is divided into a dorsal portion, the esophagus, and a ventral portion, the respiratory diverticulum or the lung bud. Firstly, the esophagus is short, but with descent of the heart and lungs, the esophagus lengthens rapidly. The muscular coat of the esophagus is derived from visceral mesoderm, and it is striated in the upper two-thirds. The muscular coat is smooth in the lower third of the esophagus. Anomalies of the esophagus. Atresia of esophagus and esophageal fistula. Mostly is the result of spontaneous deviation of tracheoesophageal septum in the posterior direction. As a result, the proximal part of the esophagus ends as a blind sac, and the distal part is connected to the trachea by a narrow canal just at the point of tracheal bifurcation. Atresia of esophagus prevents the normal passage of amniotic fluid into the intestinal tract, leading to the accumulation of excess fluid in the amniotic fluid, called polyhydramnios. Stomach. The stomach appears as a fusiform dilation of the foregut during the 4th week of development. During the following weeks, its appearance and position change greatly as a result of the different rates of growth of its wall and the changes in position of surrounding organs. The stomach rotates 90-degree clockwise around its longitudinal axis. This is longitudinal axis. So the stomach rotates 90-degree clockwise around its longitudinal axis, causing its left side face anteriorly and its right side to face posteriorly. This explains why the left vagus nerve innervating the right side and the right vagus nerve innervates the left side. During this rotation, the posterior wall of the stomach grows faster than anterior portion, forming the greater and lesser curvatures. The posterior wall grows rapidly than anterior wall, forming the greater and lesser curvatures. The stomach rotates around an antero-posterior axis. Antero-posterior axis, such that the caudal or pyloric part moves to the right and upwards. The cephalic or cardiac portion moves to the left and slightly downwards. Pyloric portion moves to the right and upward. Cardiac moves to the left and slightly downwards. This is the final shape of the stomach. Formation of the omental bursa or lesser peritoneal sac. The rotation of the stomach around the longitudinal axis pulls the dorsal mesogastrium to the left and the ventral mesogastrium to the right. This creates a space behind the stomach known as the omental bursa or lesser peritoneal sac. This is omental bursa, a space behind the stomach. Rotation of the stomach about its anterior-posterior axis, the dorsal mesogastrium bulges down, forms a double-layered sac extending over the transverse colon and the small intestine lobes. This double-layered sac is the greater omentum. The dorsal mesogastrium bulges down and form a double-layered sac called the greater omentum. Later, its two layers fuse to form a single sheet hanging from the greater curvature of the stomach. The posterior layer of the greater omentum also fuses with the mesentery of the transverse colon. Later, the two layers fuse to form a single sheet hanging from the greater curvature of the stomach. The posterior layer of the greater omentum fuses with the mesentery of the transverse colon. Anomalies of the stomach include biliary stenosis. Biliary stenosis occurs when the circular or to a lesser degree longitudinal musculature of the stomach in the region of the pylorus is hypertrophied. And biliary stenosis is one of the most common anomalies in newborns. The treatment is a surgical excision of the thickened sphincter. Biliary stenosis is characterized by an extreme narrowing of the biliary lumen, and the passage of food is obstructed, resulting in severe projectile vomiting. Duodenum. The terminal parts of the duodenum the terminal or caudal part of the foregut together with the cranial part of the midgut together form the duodenum. So the duodenum begins to develop from two sources: the caudal or terminal part of the foregut and the cranial part of the midgut. The junction of these two parts is directly distal to the origin of the liver bud. As the stomach rotates, the duodenum takes on the form of C-shaped loop and rotates to the right. The duodenum rotates to the right. And appear, the duodenum is located against the dorsal abdominal wall in retroperitoneal position. Development of the liver and gallbladder. The liver primordium appears in the middle of the third week as an outgrowth of the endodermal epithelium at the distal end of the foregut. Outgrowth of the endodermal epithelium at the distal end of the foregut. This outgrowth, the hepatic diverticulum or liver bud, consists of rapidly proliferating cells that penetrate the septum transversum. Septum transversum is a plate of mesoderm. While hepatic cells continue to penetrate the septum, the connection between the hepatic bud or hepatic diverticulum and the foregut, the duodenum, narrows, forming the bile duct. This is the bile duct. The connection between the hepatic diverticulum and the duodenum narrows, forming the bile duct. A small ventral outgrowth is formed by the bile duct, and this outgrowth gives rise to the gallbladder and the cystic duct. This is liver bud or hepatic diverticulum, the connection between the liver bud and the duodenum narrows, forming the bile duct. A small outgrowth from the bile duct gives rise to the gallbladder and cystic duct. This is gallbladder and this is cystic duct. This is bile duct. During further development, epithelial liver course intermingle with vitelline and umbilical veins which form hepatic sinusoids. Liver cores differentiate into the parenchyma, the liver cells, and form the lining of the biliary ducts. The hematopoietic cells, Kupffer cells, and connective tissue are derived from the mesoderm of septum transversum. The surface of the liver that is in contact with the future diaphragm is never covered by peritoneum. It is called the bare area of the liver. Anomalies of gallbladder. First one is the septate gallbladder. The lumen of the gallbladder is divided into several segments with partial septi. Double gallbladder. Two gallbladders are present that are connected with the cystic ducts. A floating gallbladder. Gallbladder is lined by peritoneum on both surfaces and is free from the liver. The pancreas. The pancreas is formed by two separate pancreatic buds, ventral pancreatic bud and dorsal pancreatic bud. The dorsal pancreatic bud forms as an outgrowth from the dorsal wall of the duodenum, while the ventral pancreatic duct forms as an outgrowth from the ventral wall of the duodenum along with the bile duct. When the duodenum rotates to the right and becomes C-shaped, the ventral pancreatic bud moves dorsally. Finally, the ventral bud comes to lie immediately below and behind the dorsal bud. Later, the parenchyma and the duct system of the dorsal and ventral pancreatic buds fuse. The ventral bud forms the uncinate process and the inferior parts of the head of pancreas. The remaining part of the gland is derived from the dorsal bud. The main pancreatic duct is formed by the distal part of the dorsal pancreatic duct and the entire ventral pancreatic duct. The proximal part of the dorsal pancreatic duct either is obliterated or persists as a small canal, the accessory pancreatic duct. In the third month of fetal life, pancreatic islets of Langerhans develop from pancreatic tissue. Insulin secretion begins at the 5th month. Glucagon and somatostatin secreting cells also develop from parenchymal cells. Pancreatic abnormalities. An annular pancreas. The right portion of the ventral bud migrates along its normal route, but the left migrates in the opposite direction. In this manner, the duodenum is surrounded by pancreatic tissue, and an annular pancreas is formed. The malformation sometimes constrict the duodenum and cause complete obstruction. Midgut gives rise to the distal half of the duodenum, jejunum, ileum, cecum, appendix, ascending colon, the proximal 2/3 of the transverse colon. Development of the midgut is characterized by rapid elongation of the gut and its mesentery, resulting in the formation of the primary intestinal loop. At its apex, the loop remains in open connection with the yolk sac by a narrow vitelline duct. The cephalic limb of the primary intestinal loop develops into the distal part of the duodenum, jejunum, and part of the ileum. The caudal limb becomes the lower portion of the ileum, the cecum, appendix, ascending colon, and the proximal 2/3 of the transverse colon. This arrow shows the rotation of the small intestine about 90-degree counter clockwise, causing the cephalic limb to move caudally, and the caudal limb moves anteriorly or cranially. And this figure shows intestinal loop after 180 counterclockwise rotation. We can see the transverse colon passes in front of the duodenum. Development of a primary intestinal loop is characterized by rapid elongation. As a result of rapid growth and expansion of the liver, the abdominal cavity becomes too small to contain all the intestinal loops, and they enter the extraembryonic cavity in the umbilical cord during the 6th week of development, and this process is called physiological umbilical herniation. The primary intestinal loop rotates around an axis formed by superior mesenteric artery, and this rotation is counterclockwise, and it amounts to approximately 270 when it is complete. Rotation occurs during herniation about 90 degrees and during return of the intestinal loops into the abdominal cavity, the remaining 180 degrees. During physiological herniation 90 degrees, and during return of the intestinal loop to the abdominal cavity about 180 degrees. The total amount of rotation is about 270 degrees. The cecal bud, which appears at about the 6th week as a small conical dilation of the caudal limb of the primary intestinal loop. This is the cecum. This is the cecal bud. Appears at the 6th week as a small conical dilation of the caudal limb of the primary intestinal loop. So it is the last part of the gut to re-enter the abdominal cavity. The distal end of the cecum forms a narrow diverticulum, the appendix. Anomalies of the mid-gut. First one is the omphalocele, physiological intestinal hernia. Involves herniation of the abdominal viscera through an enlarged umbilical ring. The viscera, which may include liver, small and large intestines, stomach, spleens, or gallbladder, are covered by amnion. Gastroschisis, absence, anterior abdominal wall, is the term applied to protrusion. Gastroschisis is the term applied to a protrusion of abdominal content through the body wall directly into the amniotic cavity. It occurs lateral to the umbilicus, usually on the right, and the defect is most likely due to abnormal closure of the body wall around the connecting stalk. Viscera are not covered by peritoneum or amnion. Mucous diverticulum or ileal diverticulum. Persistent ventral duct. In 2 to 4% of people, small portion of the ventral duct persists, forming an outpocketing of the ileum called mucous diverticulum. Patent ventral duct or umbilical fistula. The ventral duct remains patent over its entire length, forming a direct communication between the umbilicus and the intestinal tract. So the fecal discharge from the umbilicus. Hindgut gives rise to the distal third of the transverse colon, descending colon, sigmoid colon, rectum, upper 2/3 of the anal canal. The internal lining of the hindgut form also the endoderm of the hindgut also form the internal lining of the bladder and urethra. The terminal portion of the hindgut, enters into the posterior region of the cloaca, the anorectal canal, the primitive anorectal canal. The terminal portion of the hindgut enters the posterior region of the cloaca, which is the primitive anorectal canal. The allantois enter the anterior portion of the cloaca. It is the primitive urogenital sinus. Primitive anorectal canal, primitive urogenital sinus. The cloaca itself is an endoderm-lined cavity covered at its ventral boundary by a surface ectoderm. This boundary between the endoderm and ectoderm form the cloacal membrane. This is a cloacal membrane, a boundary between ectoderm and endoderm. A layer of mesoderm, the urorectal septum, separates the regions between the allantois and the hindgut. This septum is derived from mesoderm. As the embryo grows, the tip of the urorectal septum, the tip of this septum comes to lie close to the cloacal membrane. The tip of this septum comes to lie close to the cloacal membrane. At the end of the 7th month, the cloacal membrane ruptures, creating the anal opening for the hindgut and the ventral opening for the urogenital sinus. Between the two, the tip of the urogenital septum forms the perineal body. This is perineal body. The upper part, 2/3 of the anal canal, is derived from endoderm. The lower part, 1/3, is derived from ectoderm around the proctodium. This region is called the proctodium. Ectoderm in the region of the proctodium on the surface of part of the cloacal proliferate and invaginate to create the anal pits. Second part of this lecture is about the development of respiratory system. When the embryo is 4 weeks old, the respiratory diverticulum or lung bud appears as an outgrowth at the ventral wall of the foregut. When the lung bud expands caudally, the two tracheoesophageal ridges fuse to form the tracheoesophageal septum, separate the lung bud from the foregut. The foregut is divided into a dorsal portion, the esophagus, and a ventral portion, the trachea and the lung buds. This is a sagittal section through the cephalic end of 5-week embryo, showing the respiratory diverticulum communicates with the pharynx through the laryngeal-tracheal orifice. This is laryngeal-tracheal orifice. Epithelium of the internal lining of the larynx, trachea, bronchi, the lungs is entirely of endodermal origin, while the cartilage muscular connective tissue components of the trachea and lungs are derived from visceral mesoderm surrounding the foregut. Formation of the larynx. The internal lining of the larynx originates from endoderm. The internal lining of the larynx originates from the endoderm. The cartilage and muscles originate from the 4th and 6th pharyngeal arches. The mesenchyme of the 4th and 6th pharyngeal arches rapidly proliferates, causing the laryngeal orifice to change the shape from sagittal slit into T-shaped opening. The mesenchyme of the 4th and 6th pharyngeal arch transform into thyroid, cricoid, and arytenoid cartilage. Epiglottis is derived from the mesenchyme of the 4th pharyngeal arch during 5th week of gestation. The laryngeal epithelium proliferate rapidly, resulting in temporary occlusion of the lumen. Thereafter, vacuolization and recanalization produce a pair of lateral spaces called the laryngeal ventricles. Laryngeal ventricles or spaces are bounded by folds of tissue differentiate into folds and true vocal cords. The formation of trachea and bronchi. During lung buds separate from the foregut, the lung bud forms the trachea and two lateral outbucketings, the bronchial buds. At the beginning of the 5th week, each bud enlarges to form right and left main bronchi. The right main bronchi forms 3 secondary bronchi and the left forms 2 secondary bronchi. During further development, secondary bronchi divide into 10 tertiary or segmental bronchi in the right lung and 8 tertiary or segmental bronchi in the left lung, creating the bronchopulmonary segments of the adult lung. By the end of the 6th month, approximately 17 generations of subdivision are formed. Before the bronchial tree reaches its final shape, an additional 6 divisions form during postnatal life. This is the trachea. Form 2 outbucketings called the bronchial buds. These buds enlarge, forming the right and left main bronchi. The right main bronchus form 3 secondary bronchi. The left main bronchus form 2 secondary bronchi. Thus, each secondary bronchi give rise to 10 tertiary or segmental bronchi in the right lung and 8 tertiary or segmental bronchi in the left lung. Formation of the pleura. With subsequent growth in caudal and lateral directions, the lung buds expand into the abdominal cavity. So the lung bud is found in 2 spaces called pericardio-peritoneal canals. These canals narrow and separate from pericardial and peritoneal cavities to form the primitive pleural cavity. The mesoderm covering the outsides of the lung form the visceral pleura, while the somatic mesoderm covering the inside of the abdominal wall forming the parietal pleura. The space between visceral pleura and parietal pleura is the pleural cavity. Up to the 7th month, the bronchioles divide rapidly into more and smaller canals, and this phase is called canalicular phase, and vascular supply increases steadily. Terminal bronchioles divide to form respiratory bronchioles. We can see terminal divided into respiratory bronchioles. The lining epithelium of the terminal and respiratory at this time is simple cuboidal epithelium. The respiratory bronchiole divide to form 3 to 6 alveolar ducts. The ducts end in a terminal sacs or primitive alveoli that are surrounded by a flat alveolar epithelial cells in close contact with the neighboring capillaries. By the end of the 7th month, sufficient numbers of mature primitive sacs and capillaries are present to guarantee adequate gas exchange, and the premature infant is able to survive. During the last 2 months of prenatal life and for several years thereafter, the number of terminal sacs and capillaries increase steadily. The wall of the terminal sac or primitive alveoli is lined with flat type 1 alveolar cells. In addition to these cells, and at the beginning of the and at the end of the 6th month, another type of cells called type 2 alveolar epithelial cells produce surfactant. Surfactant is a phospholipid-rich fluid capable of lowering surface tension at the air-alveolar interface. This is lung tissue in a newborn. We can see the simple squamous of type 1 alveolar epithelial cells in contact with the capillaries, forming the blood-air barrier. Surfactant is important for survival of premature infants. When insufficient, the blood-air surface membrane tension becomes high, bringing a great risk that alveoli will collapse during expiration, resulting in respiratory distress syndrome, common cause of death in the premature infants. Before birth, the lungs are full of fluids that contains a high chloride concentration, little proteins, some mucus from bronchial glands, and surfactants. Surfactant in the fluid increases during the last 2 weeks before birth. The surfactant increases in the fluid during the last 2 weeks before birth.